Morning, everybody. Thank you for coming. I'm not sure how I ended up on this panel, given the discrepancy in experience and expertise between our... This feels more like oral boards than consultant's corner. All right, I have no disclosures. This is a 62-year-old gentleman who met me about 14 days after I joined the practice. He presented to an outside hospital with a right posterior buttock pain. He saw a general surgeon at this outside hospital. Fluctuant mass was noted, right ischiorectal fossa, right posterior. He has a history of prostate cancer in 2010, treated with external beam radiation, and he's had normal PSAs ever since with no evidence of recurrence. He also has a history of a bicuspid aortic valve and underwent an aortic valve replacement. They keep his INR a little on the high side, 3 to 3.5, because once it dipped to about 2.5 and he had a TIA. So he went to the OR for an IND of this drainage. I forget exactly how they reversed him or didn't reverse him, but he recovered fairly well, and he was seen in clinic, I think, 4 days later with persistent drainage, and they're like, oh, I better see a colorectal surgeon. So they found me. And so I saw him about, say, 2 months after this operation. He had a posterior midline internal opening that was palpable on digital exam, as not exactly easily visible on physical exam in the office. But it was felt to be right at the top of the sphincter complex. And then he had an external opening about 6 centimeters in the right posterior position over the ischiorectal fossa, and there was pus emanating from the external opening. He said he was in a little bit of discomfort. It hurt to sit for a long time. He otherwise felt okay. He was just annoyed by this drainage. And what would you do next? Jeff, do you start with EUA? Do you start with imaging? Do you do both?
Oh, this is definitely a case to refer to your junior partner.
Okay.
We do not, our radiology department does not do a great job with MRI, so I haven't personally found them helpful. But, I think you could infer that this is a deep postanal space abscess, and maybe is it on the right side, like a small right hemi-horseshoe. To me, that's a good indication for leaving a posterior midline seton to drain the deep postanal space abscess. And sometimes I don't do anything other than that, because that sometimes controls the drainage enough. He's certainly at high risk if you're going to, because of his anticoagulation situation, if you're going to have to root around and do more. But I might see if that controls the symptoms.
Okay. Anybody else do anything else?
No, I think that's very reasonable.
Imaging and an EUA?
I mean,
imaging and an EUA, yep.
Okay. So that's what I did too. I also got an ultrasound because that allowed Anders Mellgren to take a look at this, which was a nice kind of way to get a second opinion in there. And so, but they both saw the same thing: internal opening at the top of the anal canal, external opening, right ischiorectal fossa, with a high blind tract running along the levator. When I did an EUA, there was still a fairly large cavity. I did a flexible sigmoidoscopy and ruled out any evidence of malignancy or inflammation and no diverticular disease. I opened up the external cavity and debrided it and was able to place a seton through this cavity. I did not open up the deep postanal space in the midline. I just placed a seton through. But what would you do next, and how do you deal with these large cavities with high blind tracts? Or do you do anything with this guy at this point? Ian?
I'm just curious, like to poll the panelists, because I would do what you had done there. I would want to debride that tract out, and I would probably put the seton drain in through that tract and follow it through. Just curious if anybody else would try to let that tract heal and try to actually open up in the midline and place the seton in the midline. I personally wouldn't do that. I would put it in laterally through the tract.
so I think in my hands it would depend on exactly how wide that lateral tract was. If it's pretty close to the posterior midline, I'd just put a seton in. If it's out laterally, then I think you need better drainage of the posterior midline, and I would make an incision and put the seton in the posterior midline and drain the external portion.
And I agree with that.
Okay.
I agree with Ann too.
Smart man.
So, thinking
But
forward,
we haven't addressed the high blind tract. What would you do with the high blind tract?
well, what would you do with the high blind tract, Dr. Lowry?
Well, here, you got to ask John that.
John,
He raised the
yeah.
question.
I know how this game is played. I ask the questions, not the other way around.
So, when you drained the cavity,
Yeah.
were you in the high blind tract?
I felt like I could actually take a Yankauer sucker and, like, this was a big cavity, and cross the midline over to the other side, to the left side,
Cross the midline to the other side?
to the other through the deep postanal space. There's like a horseshoe.
Yeah, then I would drain the posterior midline. And it sort of depends how big these people are. A small person, I think you can get adequate drainage. A big, heavy person, you might have to put a Malancot in. I am not a big fan. I know the patients hate them, but somehow you have to be sure that the superior portion of it's drained.
Agreed.
Okay. So, and then my other thought is, what would you tell this guy about, is there any chance of fixing this? I mean, is it just seton for life? Are we just getting, he's had radiation proctitis. You're going to have to hold his anticoagulation for some period of time and manage that with any sort of formal repair. Obviously, at this stage, you're just trying to kind of assess the situation and see what happens, but thinking forward.
I think right now I personally would tell this guy that time is your friend. You had a big cavity. You had to drain a high blind tract with a big lateral abscess cavity. You have it drained now, at least fairly well with a seton in, but you still have all of that tissue around there that needs to heal. I'm going to give this guy a lot of time to let that heal in. And then when we do decide whether we leave a seton for life or whether we try one of these options, it's really going to have a good strategy of figuring out whether his anticoagulation can be held safely. That would be a part of it. But I would say probably at least 8 weeks with a seton at this point.
Okay. That's what I did too, except I waited a year, and I did 3 more EUAs, and eventually got this tract to heal down. Minimal output, no pus, well drained, no symptoms, no pain. And he says, yeah, I really want this seton out of my butt. And what's your options? And I said, well, with the radiation, not too fond of like doing a lift or an endorectal advancement flap. And I said, I know these plugs don't work because I looked at that data, and our data at Cleveland Clinic, Florida, was that they worked 15% of the time. And I said, well, 15 is better than 0, and that's roughly the Vikings' chances of making it to the Super Bowl. So I said, let's give it a whirl, because I'm a believer. And so we brought him into the hospital, and we bridged him with Lovenox, but then kept him on a drip, heparin drip postoperatively for I think 3 or 4 days, and monitored him, and then ramped up his Coumadin. For something that's usually an outpatient operation, was a bit much. But then he came back 3 weeks afterwards with a recurrent abscess, and I drained that and put a seton back in. He decides he doesn't want any further treatment, and I'm like, okay, you got a seton, things are controlled, you're not gonna, case is closed. He comes back 6 months later. Well, he comes back 5 years later. He says the seton fell out or broke or something, like maybe 2 years after it was put in. He says he's been doing okay. He gets some intermittent discomfort and drainage over 5 years. the drainage would occasionally stop. He basically then said he'd been having no drainage for a couple of weeks and thinks he has another abscess. So I take him to the OR for an exam under anesthesia. He again has a fluctuance and tenderness over the right posterior ischiorectal fossa, and he has an external opening that's scarred over, and I open that up, and then when I do a rectal exam, there's a 4-centimeter mass in the posterior midline with mucin in the anal canal when I open up the prep bivalve, and there's a mucinous adenocarcinoma.
Is this from his rectum or his prostate?
It's posterior midline, colorectal adenocarcinoma. Do people, when they're doing fistulotomies and fistulas or talking to patients about long-term seton drainage or long-term, do you talk about the risk of cancer? Do you send curettings? Jeff?
I never have. I've never seen this happen, and I'm way conservative with deep post-anal space abscesses because I think they're so difficult to fix. So I have a few patients that have had setons for a year or two. I usually then take them out, and they're often not very symptomatic after I take them out, but they haven't had radiation. I think the radiation is a player here.
John?
I think the radiation is a player as well, but I also think chronic inflammation and the fact that the seton had been there for 5 years is a fairly long time, and he hadn't been followed up at all in that time period. Is that correct? That's a tough one. And if someone has a seton over a long period of time, I try to be sure that patient comes back from time to time to rule out just exactly this problem, because we have seen that at Mayo.
So do you see them like every year, every other year?
It really depends, but I think yearly is reasonable.
I think if you try to follow up less frequently than yearly, then the patients will lose track of it and forget about it. Yearly, they can remember.
So I staged him with an MRI of the pelvis and a CT of the chest, abdomen, pelvis. It was very difficult to visualize the primary due to the large amount of mucin, but essentially the mucin and inflammation and filled bilateral ischiorectal fossa in a horseshoe pattern, so stages of T4N1. This isn't a rectal cancer talk, but I thought what would you guys do now, Dr. Lowry?
Yeah, so I assume he had external beam radiation for his. So I assume that if they will not give him any more radiation,
correct,
then, and he has no distant disease,
correct,
he needs an APR.
Did you do anything beforehand? Anything else? Neoadjuvant chemo?
Well, you can't give him. Oh, you mean just the chemo? I don't know the answer to that. Maybe. Wouldn't hurt. I mean,
So I diverted him and talked with his oncologist, who's actually part of the Mayo system in Northfield. We gave him 8 cycles of FOLFOX and then did an APR. He had a near complete pathologic response with 5 millimeters of residual cancer and 3 nodes with acellular mucin in the nodes, and just acellular mucin in the. So saved that one.
Did you have to close them with a flap?
Yeah, I had plastics close with the flap. Thank you. I'm coming to San Francisco, though. I'm going to learn that. Okay. I believe Dr. Lowry knows this patient, so she has a strategic advantage. But it is one of my patients, 60-year-old female, history of ulcerative colitis with a hepatic flexure colon cancer, status post-total proctocolectomy here in the Twin Cities with an ileopouch anal anastomosis 25 years ago. This is noted to be a difficult case. They had some difficulty achieving adequate length for a J pouch for an ilioanal pouch, and so they created an S pouch with a hand-sewn ilioanal anastomosis. Initial pouchogram showed a small leak with a pouch vaginal fistula, and the ileostomy closure was delayed several weeks. was a little difficult in our system to see if there were any further procedures done. I don't believe that they were. The patient didn't recall any further procedures, but basically with delay and then a repeat EUA and a repeat pouchogram, there was no radiographic or clinical evidence of a pouch vaginal fistula. And so her ileostomy was reversed, and she initially says she did quite well. She has a history of 3 vaginal deliveries, all prior to her surgery. She returns 15 years later with a new onset of complaints of pouch vaginal fistula. So this is 2007. She undergoes a pouchoscopy, a pouchogram, as well as small bowel follow-through. There's no evidence of Crohn's disease. She has a long discussion and elects to have just, she can live with a little bit of gas through the vagina every once in a while. Waits for me to finish and comes back. And 10 years later, now she wants something done. She's passing gas and occasionally stool through the vagina. She has about 6 bowel movements per day. She wears a pad on a daily basis. She is obese. She has a BMI of 39, and she has a history of a ventral hernia. Take it away, Dr. Paquette. Pouch vaginal fistula.
This is Tuesday for me, basically. It's sort of this is sort of what we see. But it was important that you ruled out Crohn's. You were sort of going down the line of having some difficulty with the case at the beginning, so it was more likely going to be a technical issue. But especially when they come back that many years later, you do have to do all these steps to rule out Crohn's disease. With these fistulas, I think not every fistula has to be fixed with surgery, so I would want to know how symptomatic this patient is. You kind of described it, but I'm taking that into my account to try to see if we actually need to do something, because the solution can end up being a rather large solution.
Yeah, she says she's getting some funny looks at church. It's not smelling so great, and it's interfering with her social life. She can manage, but she's put up with it for a while.
Well, you sort of have an opportunity to see how motivated she is to fix it, because with that BMI of 39 and the ventral hernia, she has a few things going against her. So I would talk to her about that and see if she's really that motivated to fix it. I would strongly suggest weight loss. If you have a fistula that's there after you've already tried to repair it, you may end up having to do something a little bit bigger, like a pouch advancement I would personally do under the cover of a diversion. But I'm not going to go back in and do all that yet with the ventral hernia and the high BMI.
So I reevaluated her, did MRI enterography, pouchoscopy, EUA, no inflammation, no Crohn's disease, pouch looks healthy, small 2 to 3 millimeter pouch vaginal fistula, anterior midline, right at the anastomosis. She does have a fairly narrow anal canal. Really to visualize this, I had to utilize a pediatric nasal speculum to just kind of, see where this was at. Yeah. Jeff, go ahead.
Okay, I'll
He'll bite.
2 cents. One, I don't think that a ileoanal pouch is necessarily the right thing for every patient, and maybe she's proven that this is not the right thing for her with all these extra problems. But I will say that in my hospital, we have an incredibly skilled interventional GI group of people, and they have been incredibly successful at putting this thing called a bear claw, or they also have the ability to stitch in areas that we as surgeons can't reach from the outside, and they've saved some of these pouches with these devices. So particularly in a patient who's morbidly obese like this, I think it's worth a try.
Dr. Lowry, care to offer an opinion?
It isn't really fair because I do know the patient, but so first, she hadn't had a previous repair. All this time.
Is all.
She's just it's
waiting.
gone away.
Just waiting
and
with the stoma.
Yeah.
She hasn't had a stoma. She got her ileostomy closed. She had no symptoms for 15 years. Then she had symptoms. Then they went away enough to live with. And then, so I think you discuss the options with the patient, and the options include something interventional endoscopically, to put a plug in, to do an advancement. You can flap, you can advance the pouch, or you can put gracillis in between.
Yeah, I mean, she's big, but it's not like her legs are big, and
Right.
you know, so that's what we did. So I did a transperineal repair with a gracillis and a diverting ileostomy, which went great. We were high-fiving in the OR. It was awesome. Then we let the plastic surgeon operate. That's when it went downhill. But they, the gracillis actually went up fine. We were well above the repair. I never thought this was going to work, to be frank. But I thought to myself, you know, it would. I thought it was the best option to work, and because they're hard enough just in native rectal vaginal fistulas, and here we are in a pouch vaginal fistula. But we repaired both sides of the fistula and laid the gracillis in. And it failed on a post-operative study. So the way we study these is with an MR of the pelvis with vaginal contrast. It's an awesome study. If you ever need a study to look at a pouch vaginal fistula, I learned this trick from Dr. Lowry, and you can see things really well. One thing you can see is the stitch of the gracillis into the pouch. So that failed. Then I'll just skip ahead since this was my mini fellowship in pouch vaginal fistulas. This is a transvaginal repair with a vaginal flap. That seemingly worked well, though she was left with a very, very tiny amount of granulation tissue when we saw her 2 months later. And I thought about reversing the ileostomy, but we waited that out, and that granulation tissue persisted, and that eventually failed. And then we did a pouch advancement, and that worked. So that was all under the cover of a diverting ileostomy. So we diverted her with that first one. And then right before I took down her ileostomy, I did her EUA. That seemed to work. We had scheduled her for ileostomy the week before. She said, you know, I've been having this back pain, and it's in the right upper quadrant, and it's radiating right to the back. And I got a CT scan, which showed a large mass in the gallbladder with metastasis to the liver. So, okay, on that fun note.
You have any happy stories, Marc?
27-year-old female underwent an IND of a left anterior perirectal abscess. This is an IND done in the OR. It's just pus noted from gland at the dentate line in the left anterior position. Did you put the seton in at the time, Ian? Or do you just drain the abscess and get out of Dodge?
So I would say most times when I'm trying to drain an abscess, I'll just try to drain the abscess and get out. I don't go, if you don't see that finding that you have there, I don't go take the abscess cavity and start probing it and try to find a fistula. Though if I do see some obvious drainage from that spot and it looks like it is something a little bit higher going through the sphincter, and it was reasonable to place a seton, I would do it at that time. But if I didn't see that, I wouldn't chase it.
Okay. You agree?
Yep.
Jeff?
Yes.
Okay. 8 weeks later, she had persistent external opening in the left anterior position, 3 centimeters from the anal verge, that's draining pus and blood intermittently. We've talked about this before. Now, what exam under anesthesia, MRI or ultrasound? We took her for an EUA first that shows a transsphincteric fistula tract involving 50% of the anal sphincter with an anterior midline internal opening. Dr. Lowry? Young woman, anterior fistula, 50% of the sphincter.
Any previous deliveries?
No.
I would, so as I commented, I'm in favor of ultrasounds just to check the internal sphincter, but if the internal sphincter was intact, I'd probably do a lift.
So non-cutting seton is placed. Is everybody doing a lift? Every slap? Cutting seton?
Yep.
Oh.
Yo.
Whoa! Whoa!
Don't talk to me about that.
Did you hear, John?
Yes. So, Dr. Pemberton, please
Yes.
get that on the record here.
Yes, a cutting seton.
Cutting seton.
Yes, I will.
Okay. All right. So we
Of
decided.
course you do a lift. Stand
I
still.
know. Yeah. No.
No, it isn't only that. It is the data about cutting setons. What do you mean? You mean forget
This
the
is
data?
what I'm here for.
Right. Well,
Arguing.
some data. Depends on where it's from.
So our data and other people's data is that a cutting seton, which theoretically you all understand is supposed to cause fibrosis so the sphincter doesn't separate and then you don't get incontinence, that is a falsehood.
Well, that's not true.
And so that you do have a significant incidence of incontinence afterwards, and particularly anteriorly in a female.
But you asked, and rightly so, this age group, has she had deliveries yet? And I agree with you that women have present a potential problem. But in our hands, anything other than a cutting seton, and a few lifts from time to time. But that's associated with a fairly high incidence of recurrence or persistence in our hands and in other people's hands. So there's more of a tendency to very, very slowly cut through the sphincter, not in 3 days.
Oh, no, not in 3 days. But I will say I think that's true. And the discussion you have with patients has to be, is your goal to fix the fistula and you don't really care what the price is? Or is your goal to avoid any incidence of incontinence and you're willing to have multiple operations in order to avoid that?
And did you say that you would do a primary lift? You don't place a draining seton?
No. I skipped a step. I would place a seton, and then once the abscess cavity had closed down to the size of the seton, I would do a lift.
Right.
Dr. Paquette.
I think I'll try to answer your questions that you have up there.
Sure.
Typically, it's about 6 weeks for a seton. That first case that you presented would be an awful lot longer because the cavity was bigger. I see them in the office and take a look to see if they're healed around it. I tend to tell them about 80% success. I tend to think it's a little bit higher than that in a lot of these patients. I wouldn't quote that for that first guy that you presented with the horrible tract. So I think you have to have reasonable expectations. I think sometimes it may just completely heal. Sometimes you'll get one of those low failures where if I can get the component through the external sphincter to heal, I think that's a win. If you have a real low component that's left into the wound with a little bit of internal sphincter alone left there in the right patient, you can just go back and do a secondary fistulotomy, which I think is an advantage of this technique.
I think Dr. Pemberton brings up a good point because you are dealing with what is the patient's expectations about multiple operations and how does multiple operations dissecting between the sphincters potentially, because your next operation might be an endorectal advancement flap. That certainly, as we saw, carries a risk of change in continence. So is it better to just take that all up front with one operation versus the chance that you could be going down multiple operations? So we did a lift. Then the lift failed. Here, I'm never going to hear the end of this one. And then, so now what? Redo lift or flap? Dr. Paquette.
I think you have to figure out how it failed and why. So you're telling me that it's a true failure, that the whole fistula tract opened back up rather than just a simple opening up into the internal wound. I probably would start over. I would think about even placing another seton drain to make sure that everything is drained out there. I would image. We used a lot of ultrasound when I was in Minnesota. We still do that. Our radiologists are actually very good with MRI as well. I would want at least some imaging to quantify to make sure that I'm not missing some accessory tract or some abscess cavity that's undrained. And then I think that if you have some clear reason why that failed, did I do that lift procedure or did somebody else do it? Can I look at the op note? I think it's reasonable to try another one, but it's also reasonable to do a flap. I think my take-home point is that you have to do what you're good at, and I'm much better at doing a lift than a flap. But I think that those things are all quite reasonable. If you're comfortable, you have a good outcome with a flap, you can do that as well.
Dr. Sternberg.
I completely agree with what Ian said. I must say, when I first started practice, I felt I was really good with flaps, and like my first 10 worked, and then the next 10 failed. But I also felt that patients were really bothered by the mucus leakage after a flap. And so I found that young patients in particular were really bothered by even they were intolerant of a small amount of mucus leakage after a flap. So I've gone to the lift, and I have redone them. They're not easy to redo. I actually think the lift so I divide and try and make it so that the two divided ends of the fistula tract are sort of not touching anymore. So I kind of fold it back into the muscle on the external sphincter side. Certainly the internal sphincter side for me is the hardest because it's such a thin muscle, but I still try and bury that. I don't close the internal opening because then I feel like you have a blind-ended thing. And then I always test with hydrogen peroxide after I've done that from the external opening and the internal opening to make sure that at least in the OR, I suture ligate it, and then I double ligate it and fold it back in. And then I loosely approximate the tissue to close the wound.
It's similar to that, but I would echo that it's important to test that you actually closed what you think you closed, because you find this tract and you divide it and put these sutures in, and it looks great that you have both ends closed off, and just doing a little bit of a test with some hydrogen peroxide. If that's really closed, there should be nothing leaking through. And then when I do close it, I leave the external skin opening open to try to give it a route to drain as well.
How do you do it, Dr. Larson?
That's what I would do.
Okay. This actually, patient actually, this was not my case, but they said, well, that didn't work, and we did all those nice, neat tricks, and something, it seems to have just recurred, so they actually went with a sliding ectorectal advancement flap. Full thickness. So that also fails with a persistent external opening. So now you've got a failed lift and a failed flap in a young woman. Dr. Lowry.
So I'm wondering if it's a hint that the colonoscopy is up there. Does she have any reason to think she has Crohn's disease?
No abdominal pain, no bloody diarrhea, nothing.
So
should you check after the first failure?
Well, I think that it's the gastroenterologists seem to think that everybody's got IBD if they have a fistula, which I do not believe. And I think a lot of people have cryptoglandular abscesses and get a fistula, and we never find IBD. But if there's anything at all concerning, then I would check after the first fail. Well, then if I was really, first if you see any red flags, you check before you do any repair. If you fail, then you check. I don't think necessarily that I would be assuming that you have to check on everybody, but I have a very low threshold.
And my threshold for checking for IBD is very low because our referrals at Mayo can be very difficult. And there's a reason, just like this, there's a reason that something's going on. And it seems reasonable to check fairly frequently for Crohn's. And it really doesn't matter if the GI workup is negative because there's a small percentage of patients who will have Crohn's disease only in the perineum.
Yeah, in some studies it's 10 to 15%. But if do you do anything presumptively? I mean, if the evaluation's negative,
Yeah.
you live with that evaluation.
Yes.
Okay. So she undergoes a colonoscopy. That's normal. Then they decided to try redo lift. There's a small external opening heals, but there's a persistent opening in the intersphincteric groove. So essentially treating this into an intersphincteric fistula, in which case a completion fistulotomy is performed and the fistula is healed. All right. Last case. We got 5 minutes. 60-year-old male, obese, history of DVT on Xarelto, posterior midline fluctuant mass, drained in the operating room into the deep postanal space. There doesn't seem to be any horseshoe connections. Returned 4 weeks later. There's persistent drainage from a posterior midline external opening. And you see him again another 4 weeks later, and there's a palpable cord from the external opening to the anal canal. Taken for an exam under anesthesia. Shows a posterior midline fistula with a posterior midline external opening, posterior midline internal opening. Feels superficial, good bulk of muscle above the opening. Dr. Pemberton, what do you do?
I would intubate the tract with a seton. Has that already been done?
So nope, you're in the operating room. You've got a Lockhart memory fistula probe through the fistula tract.
Okay, I would put a draining seton in and be sure everything's fine for X number of weeks, and then have the patient come back and reevaluate the situation. If there's no evidence of inflammatory bowel disease, then I would perform a cutting seton in the back, in the posterior midline.
Okay. Dr. Paquette?
If it's as low as you describe it and it's a judgment call, and the question is what have you done to assess how much sphincter it takes up, a primary fistulotomy may be reasonable, but I would be assessing how deep that goes into the sphincter before I did that.
Jeff? Dr. Sternberg?
I agree with Ian. I would likely perform a primary fistulotomy, but if there was any doubt, placing a draining seton as a bridging maneuver is always appropriate, I think.
So
with shortening the tract, because sounds like a long tract.
So let's say you place that seton, you do your colonoscopy, you're pretty sure this is a fairly superficial fistula. 2 questions I have for the panel is, what percentage of fistulas do you treat with just primary fistulotomy? I think we talk a lot about flaps and lifts and all these fancy sort of things, but I mean, it is the traditional operation, and it's got the one with the highest success rate.
If they're posterior, particularly in a male, as long as they aren't super high with a deep postanal space abscess, I'm fairly liberal with a fistulotomy. So probably half of my patients. Anteriorly, I'm much more conservative.
Dr. Lowry?
With females.
So certainly if it's intersphincteric, I would divide the fistula, and then it's a matter of what is superficial. So I would image the patient, and we use ultrasound generally. But if it were just the very distal part of the subcutaneous external sphincter and the internal sphincter, then I would divide it. And I'm not sure that you could do a cutting seton. I'm not sure it makes a difference. But I do not, I'm probably not as liberal with dividing the posterior sphincter complex as has been historically said. I mean, they used to say that you could divide the external sphincter up to the puborectalis and men would be continent, and I think that's not true.
Dr. Pemberton?
I would stick with my plan. Usually, posteriorly, you form a fairly large, or can form a big wound, and that's a problem with fistulotomy. If you ask what percentage of our patients, or my patients, are primary fistulotomy, very few, because of our referral basis. So I'd say less than 10%.
Dr. Paquette?
It's interesting because with a slightly different referral basis, probably do more fistulotomies primarily than some of these other techniques, but it's because of what type of patients are coming in with that problem.
All right. And with that, I just wanted to put this out there. This is a podcast that's offered by St. Mark's. They did a 2-part thing on fistulas, which is like 2 hours worth of talking about fistulas. It was quite good. It echoes a lot of the sentiments discussed here. But if you want another deep dive into fistulas and how they do them from the European perspective, I recommend the St. Mark's Hospital podcast, available on iTunes. And with that, I have 1 minute left, so I'm considering myself on time, and I'll turn it back over to Wolf and Janet and Brett. Thank you very much.